There is a number your doctor almost never tells you, a measurement that predicts your risk of type 2 diabetes, your risk of a fall that fractures your hip, your risk of cardiovascular disease, and your likelihood of living independently into your 80s with far more accuracy than your cholesterol panel or your BMI, and that number is how much functional muscle mass your body is carrying right now. Not how much you weigh. Not whether you look slim. How much of what is on your body is metabolically active muscle tissue, doing the biological work that keeps you alive and well, and how much has quietly been replaced over the past decade by fat and fibrous tissue that does none of that work at all. Most people over 60 have never had this conversation. They have had the blood pressure conversation and the cholesterol conversation and the blood sugar conversation, and those are important, but they have almost never had a doctor sit down with them and explain that the progressive loss of muscle mass, a process called sarcopenia, that begins in most adults around the age of 40 and accelerates meaningfully after 60, is one of the single strongest predictors of all-cause mortality available in clinical medicine, and one of the most consistently ignored. We want to change that today, because the research on this is not obscure or controversial. It is consistent, replicated, and increasingly the focus of the most forward-looking work in preventive medicine and longevity science. The question is not whether muscle mass matters after 60. The question is why this information has not been reaching the people who need it most, in the conversations that should be happening at every annual physical. Before anything else, what I share in this video is educational information only. It is not medical advice. If you are interested in starting or significantly changing an exercise program, please speak with your healthcare provider first, particularly if you have existing cardiovascular, orthopedic, or metabolic conditions. What I want to give you today is the understanding of why muscle mass belongs at the center of your health conversation after 60, not on the margins of it. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. The shift I see most consistently in the patients who age best, who remain independent the longest, and whose quality of life in their 70s and 80s is meaningfully better than their peers, is not the ones who restrict the most or who take the most supplements. It is the ones who have protected their muscle mass. And I want to explain exactly why that is. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body needs after 60. And this video may be among the most practically important ones I have ever made. Let me start with what muscle actually does in the body, because most people think of it in terms of strength or appearance, and while those are real benefits, they are almost the least important things on the list of what skeletal muscle tissue is doing for you biologically every moment of every day. Skeletal muscle is the largest organ in the human body by mass in a healthy adult. In a well-maintained 60-year-old, it represents somewhere between 30 and 40% of total body weight. And unlike fat tissue, which is largely passive from a metabolic standpoint, muscle is metabolically voracious. It consumes energy at rest. It demands blood flow. It secretes hormones. It stores glucose. It communicates with the brain. It participates in immune regulation. It is not a mechanical system bolted onto a biological machine. It is a biological system that is deeply integrated into almost every important physiological process the body runs. The most underappreciated function of muscle in the context of modern chronic disease is its role as the primary site of glucose disposal after a meal. When you eat carbohydrates and blood glucose rises, insulin signals cells throughout the body to take up glucose from the blood. And the tissue that accounts for the largest proportion of that glucose uptake is skeletal muscle. Roughly 70 to 80% of the glucose cleared from the blood after a meal goes into muscle tissue, where it is either burned for immediate energy or stored as glycogen for later use. This means that your muscle mass is quite literally your blood sugar buffer. The more functional muscle you carry, the larger the glucose storage reservoir your body has available. The smaller and more transient your postprandial blood glucose spikes are, and the less insulin your pancreas needs to release to manage them. The less muscle you carry, the smaller that reservoir, the larger the glucose spikes, the harder the pancreas works, and the more rapidly insulin resistance develops. A study published in the Journal of Clinical Endocrinology and Metabolism found that low skeletal muscle mass was independently associated with insulin resistance, even after controlling for body fat percentage and physical activity levels. Low muscle, high insulin resistance, regardless of how lean the person appeared. This is the mechanism by which people who look slim and eat reasonably can be developing type 2 diabetes, because the metabolic system that clears blood glucose has been quietly eroding for years, while the mirror told them they were fine. The timeline of this erosion is worth understanding specifically, because it begins far earlier than most people expect, and its early phases are almost completely invisible. After the age of 30, muscle mass begins declining at approximately 3 to 5% per decade in people who are not specifically working to preserve it. After 60, that rate approximately doubles, and after 70, in sedentary adults, the decline can accelerate further to the point where functionally significant weakness, the kind that affects daily activities and fall risk, emerges within a period of a few years, rather than a few decades. What makes this particularly insidious is that the body compensates for the lost muscle volume by depositing fat into the same space. The leg that looks the same size in the mirror may contain substantially less functional muscle and substantially more intramuscular fat than it did 10 years ago. The scale weight is unchanged. The BMI is unchanged, but the metabolic function and the mechanical strength of that tissue have been degrading the entire time. This is the hidden biology that makes muscle mass a more informative health metric than weight or BMI for adults over 60, and it is precisely why those metrics are so poor at capturing the actual health trajectory of an aging body. The first major consequence of progressive muscle loss I want to address is the one with the most direct mortality data, and the one that most dramatically reframes how we should be thinking about metabolic health in adults over 60. The relationship between low muscle mass and premature death is not a weak association or a preliminary finding. It is among the most robust signals in the epidemiological literature on aging. A landmark study published in the American Journal of Medicine followed more than 3,600 adults over 60 and found that those in the lowest quartile of muscle mass relative to body size had a mortality rate approximately 2 to 3 times higher than those in the highest quartile, after controlling for age, cardiovascular risk factors, and metabolic conditions. 2 to 3 times higher, not from an acute illness or a genetic condition, from the progressive loss of a tissue that most people assume is simply cosmetic. The mechanism connecting low muscle mass to higher mortality operates through several pathways simultaneously. Low muscle mass is associated with metabolic dysregulation, specifically the insulin resistance and chronic low-grade inflammation that accelerate cardiovascular disease and type 2 diabetes. It is associated with immune impairment because muscle tissue secretes myokines, signaling proteins that modulate inflammatory tone throughout the body, and losing muscle means losing those immunoregulatory signals. It is associated with reduced physiological reserve, the margin between the body's resting capacity and the capacity required to survive an acute stressor like a serious illness, surgery, or injury. And it is associated with the falls and fractures that, in older adults, carry their own significant mortality risk, independent of everything else. What makes this particularly important is that the mortality association exists independent of fat mass. A person who carries substantial fat but maintains adequate muscle mass has a better survival profile than a person who is slim but muscle depleted. Researchers have coined the term sarcopenic obesity to describe the combination of low muscle and high fat that is increasingly common in adults over 60 who have lost muscle without necessarily gaining weight visible on a scale, because the muscle was replaced by fat volume for volume in a process that the BMI and the tape measure completely miss. Type in the comments right now whether your doctor has ever measured your muscle mass or assessed your muscle strength as part of a health evaluation, because the answer to that question is going to show me how commonly this critical piece of the health picture is being evaluated in routine care. The second major consequence is falls and fractures, and I want to spend real time on this because the mortality data on falls in older adults is stark enough that it deserves to be understood clearly rather than treated as a background concern. Falls are the leading cause of injury-related death in adults over 65 in the United States, and the numbers have been rising. More than 1 in 4 adults over 65 falls each year. Of those who fall and fracture a hip, approximately 20 to 30% die within the year following the fracture, and a significant proportion of those who survive never regain full independence. This is not a minor health statistic. It is a major cause of death and functional loss in the population, most likely to be watching this video right now. The connection between muscle mass and fall risk is direct and mechanistic. The muscles of the lower limb, particularly the quadriceps at the front of the thigh, the hip abductors, and the ankle dorsiflexors, are responsible for postural stability, for the rapid corrective contractions that catch a stumble before it becomes a fall, and for the bone loading that maintains bone density and structural integrity in the hip, the spine, and the femur. When these muscles weaken, balance becomes less reliable. The corrective response time after a stumble lengthens, and the bone that the weakened muscle is no longer loading loses density through the biological mechanism of disuse-driven resorption. A study published in the Journal of Bone and Mineral Research found that grip strength, which is a validated surrogate marker for overall skeletal muscle function, was independently predictive of hip fracture risk in adults over 65. Low grip strength, high fracture risk, and the association held even after controlling for bone density, meaning that the muscle component was contributing independently of its effect on bone. The clinical implication is that grip strength measurement, a test that takes 30 seconds with a simple handheld dynamometer, provides meaningful prognostic information about fall and fracture risk. Ask your doctor to measure your grip strength at your next appointment. It is not an exotic test. It is a standard validated tool that is simply rarely used in routine primary care, despite robust evidence for its predictive value. And share this video right now with one person in your life over 60 who has mentioned concerns about balance, who has had a fall, or who has been told their bone density is decreasing, because the muscle piece of that conversation is almost certainly the one that has not been addressed. I want to tell you about Margaret, 72 years old, retired nurse from Chicago, Illinois. She came to me not because of a fall, but because she was worried about one. She had noticed over the previous 2 years that getting up from a chair required more effort than it used to, that stairs had become something she thought about rather than simply did, and that she had stumbled twice in the past 6 months, catching herself both times, but unsettled by the fact that catching herself had felt effortful in a way it never had before. Her weight was stable, her blood pressure was managed, her cholesterol was within range. By every standard metric of her annual physical, Margaret was fine. When I assessed her muscle function specifically, measuring grip strength and performing a timed up-and-go test, which measures how long it takes a person to stand from a chair, walk 3 meters, turn, and sit back down, both results were in the lower range for her age group. Her quadriceps strength was below what would be expected for a woman her age and size, and her self-reported physical activity had declined significantly since she retired, partly from reduced daily walking and partly from a mild knee arthritis that had made her reluctant to load the joint. Margaret did not have a crisis. She had a trajectory toward the fall she had not yet had, the fracture that follows it, and the loss of independence that too often follows that. We built a specific program around her, resistance training twice weekly, modified for the knee, focused on the muscles responsible for postural control, and the hip and ankle stabilizers most protective against falls. A protein intake review, because she was eating well below the amount needed to support muscle protein synthesis in an older adult, a gap that is nearly universal in the older adults I see, and a conversation with her orthopedist about managing the knee to allow the loading the muscle needed. At 6 months, her timed up-and-go time had improved by 4 seconds, which is clinically meaningful, and her grip strength had increased. She told me at that appointment that the stairs no longer required a decision, they were just stairs again. And she told me, nobody had ever told me that my muscles were a health issue. I thought exercise was for losing weight. That distinction between exercise as weight management and muscle maintenance as a survival system is the entire point of this video. The third major consequence I want to address is the connection between muscle loss and cognitive decline, because the research in this area has moved rapidly in the past decade, and the findings are significant enough to belong in any complete conversation about why muscle mass matters after 60. The brain and the skeletal muscle system are in continuous biochemical communication through a family of signaling molecules called myokines. These are hormones secreted by muscle tissue during contraction, and they travel through the bloodstream to the brain, where they produce specific protective effects. The most studied of these is a myokine called irisin, which is released primarily during exercise and which promotes the expression of BDNF, brain-derived neurotrophic factor, in the hippocampus. BDNF is the primary growth factor for neurons in the hippocampus, the brain region most critically involved in memory formation and most vulnerable to the early stages of Alzheimer's disease pathology. In animal models, irisin infusion has been shown to reduce amyloid plaque formation, the pathological protein aggregation characteristic of Alzheimer's disease, and to improve cognitive performance. In human observational studies, lower circulating irisin levels have been associated with higher rates of cognitive decline and dementia. The studies are not yet at the level of confirming causation, but the biological plausibility is strong, and the consistency of the association across multiple research groups is notable. Beyond irisin, muscle tissue releases a range of anti-inflammatory myokines during contraction that suppress the chronic low-grade systemic inflammation associated with neurodegeneration. The inflammatory cytokines that drive the progression of Alzheimer's disease, TNF-alpha, interleukin-6 in chronically elevated states, and IL-1 beta, are suppressed by the anti-inflammatory signals that working muscle produces. A body that is regularly contracting its skeletal muscle is a body that is running a continuous endogenous anti-inflammatory program that benefits the brain as directly as it benefits the cardiovascular system. A study published in the journal Neurology found that higher grip strength in adults over 60 was associated with a significantly lower risk of dementia over a 10-year follow-up, after controlling for cardiovascular risk factors, education, and physical activity levels. The association was graded: higher strength, lower dementia risk, and it held even in adults who were not meeting general physical activity guidelines, but who simply maintained higher muscle function. The muscle itself, independent of the exercise that built it, was carrying a protective signal. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell, because the depth of the research connecting the body's largest organ to long-term cognitive health is exactly the kind of information I come here to deliver every week. Let me now talk about protein, because it is the nutritional foundation of everything I have described, and because the recommended daily intake that most older adults have been told about is systematically insufficient for muscle protein synthesis after 60. The standard recommended dietary allowance for protein in adults is 0.8 grams per kilogram of body weight per day. This number was set as the minimum required to prevent deficiency in a general population, not as the optimal intake for maintaining or building muscle mass in an aging body. For older adults, the anabolic response to protein, the degree to which consumed protein stimulates muscle protein synthesis, is blunted compared to younger adults. Older muscle tissue requires a higher protein stimulus to trigger the same synthetic response, and the current RDA applied to an older adult is simply not enough to maintain muscle mass over time, let alone to support any meaningful gain. The research consensus in sports medicine, geriatrics, and nutritional science now consistently recommends protein intakes in the range of 1.2 to 1.6 grams per kilogram of body weight per day for adults over 60 who are active or seeking to maintain muscle mass, with some researchers arguing for even higher targets in those with sarcopenia. For a 75-kilogram adult, that is 90 to 120 grams of protein daily, compared to the 60 grams that the RDA would suggest. The difference is substantial. In most older adults I assess are eating below even the insufficient RDA target. The distribution of protein across meals also matters. Muscle protein synthesis is stimulated by the presence of essential amino acids in the blood, above a threshold level, and each meal that provides adequate protein generates a synthetic stimulus lasting several hours. A day of eating in which a large proportion of protein is concentrated at dinner, with minimal protein at breakfast and lunch, produces far less total synthetic stimulus than the same total protein distributed evenly across 3 meals. Approximately 30 to 40 grams of high-quality protein per meal appears to be the threshold required to maximally stimulate synthesis in older adults, which means that a light breakfast of cereal and a light lunch of soup, even if dinner is protein-rich, leaves the morning and midday synthetic windows essentially empty. Leucine is the specific amino acid most responsible for triggering the muscle protein synthesis signal, and foods highest in leucine per serving are animal proteins: eggs, fish, chicken, beef, dairy. Plant proteins can provide adequate leucine, but typically require higher serving sizes to reach the threshold, and some plant protein sources have lower digestibility coefficients that reduce the effective dose reaching the bloodstream. This is not an argument against plant-based eating. It is an argument for ensuring that whatever protein sources are chosen, the daily and per meal targets are actually being met rather than assumed. A study published in the American Journal of Clinical Nutrition found that evenly distributed higher protein diets in older adults produced significantly greater improvements in muscle mass and physical function compared to the same total protein concentrated in 1 or 2 meals, and that adults eating the RDA recommended amount showed no meaningful preservation of muscle mass over the study period compared to the higher intake groups. Here is the practical framework I want you to take away from this video, because the research I have described has direct, actionable implications for what to do starting this week. The first priority is resistance exercise. Not cardio, not walking, though walking is beneficial for cardiovascular health and falls prevention in its own right. Resistance exercise, meaning exercise that loads the muscles against meaningful external resistance, whether through free weights, machines, resistance bands, or bodyweight exercises, is the primary stimulus for muscle protein synthesis and the primary defense against sarcopenia. 2 to 3 sessions per week, targeting the major muscle groups with particular emphasis on lower body strength for falls prevention, is the evidence-based starting point for adults over 60 with no prior exercise history. Start conservatively. Focus on form. Progress gradually, but start. The second priority is protein intake. Calculate your target, 1.2 to 1.6 grams per kilogram of body weight per day, and compare it to what you are currently eating. The gap between these numbers for most adults over 60 is large. Distribute that protein across 3 meals, aiming for 30 to 40 grams per meal. Prioritize complete protein sources with high leucine content: eggs, fish, chicken, Greek yogurt, cottage cheese, and for those preferring plant sources, legumes with soy products or complemented with dairy. The third priority is the medical conversation. Ask your doctor to measure your grip strength and to discuss your muscle function as a specific component of your health assessment, separate from your weight and your BMI. Ask whether a body composition assessment, measuring fat mass and lean mass separately, rather than just total weight, is available and appropriate for you. These assessments change the conversation from "are you a healthy weight" to "is your muscle to fat ratio supporting your metabolic health, your fall risk, and your long-term independence," which is the question that actually matters. And the fourth priority is vitamin D. Vitamin D deficiency is prevalent in adults over 60 and directly impairs muscle function through its role in muscle cell calcium handling and protein synthesis. A fasting vitamin D level below 30 nanomoles per liter is a meaningful contributor to muscle weakness and fall risk and should be corrected in conversation with your doctor before attributing poor muscle function entirely to aging or inactivity. Type yes in the comments right now if you have never been told to prioritize muscle maintenance as a specific health strategy, separate from weight management. Because yes in that comment is the statement of a gap in healthcare communication that this video exists to close. 4 things to carry away. First, muscle mass is the body's largest glucose storage organ, and its progressive loss is one of the primary mechanisms driving insulin resistance and type 2 diabetes in adults over 60 who appear to be eating reasonably. The blood sugar system is a muscle system, and it depends on the muscle being there to do the work. Second, falls and fractures kill and disable more adults over 65 than most people realize, and the single most modifiable risk factor for falls is lower limb muscle strength. Grip strength measurement is a validated 30-second clinical test that predicts fracture risk, functional decline, and mortality, and it is almost never performed in routine care. Just ask for it. Third, muscle tissue secretes anti-inflammatory myokines and BDNF-stimulating signals during contraction that protect the brain against neurodegeneration. The connection between muscle maintenance and cognitive protection is biological, not motivational. It operates through specific molecules on specific receptors in the hippocampus, and losing muscle means losing those signals. Fourth, building and maintaining muscle after 60 is physiologically possible. It is well documented. It requires specific inputs, which are resistance exercise and adequate protein, and it is the single intervention with the broadest evidence base for extending both the length and the quality of life in this age group. You are not too old for this. The older you are, the more you need it, and the more precisely targeted the effort needs to be to produce results that matter. Your muscle is not an aesthetic concern. It is a survival system. It is the tissue that buffers your blood sugar, catches you when you stumble, signals anti-inflammation to your brain, and gives your body the metabolic reserve to survive the acute stressors that aging brings. Letting it decline without a fight, without resistance training, and without adequate protein is letting one of the most protective systems in your body quietly run down, while everyone focuses on the number on the scale. Share this video with one person in your life over 60 who has been told they need to lose weight, but has never been told they need to build muscle, because those are not the same conversation, and the second one is more important. And subscribe to this channel, because every week I come here with one purpose: to give you the specific information that changes not just what you know, but what you do. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.